Well, hello, I'm Kathy Posnick, and I'm glad we got to know each other a little bit and talk. And I wanted to tell you a little bit about CSF and what CSF is doing right now to give you an update. Some of you haven't been to any of our events for a while, Brenda, so I wanted to kind of update you on what's been going on. But CSF continues to distinguish itself as a leading charity and fundraising nonprofit for Chiari, Syringomyelia, and related disorders in the U.S., and I want to take a couple minutes to tell you about that and what we've been doing. We are very proud that we are CSF is the only charity for Chiari, Syringomyelia, and related disorders like hydrocephalus and Ehlers-Danlos syndrome that has met the 20th rigorous standards of the Better Business Bureau's Charity Accountability Program. We have earned the Platinum Seal from GuideStar and have received the Health on the Net Code, or the HON Code certification, which means the information on the CSF website is medically reliable, current, and scientifically accurate. CSF has hosted over 350 educational lectures like this one tonight. Everyone is videotaped and put on our website, and those videos have been accessed 1.6 million times. So we are educating, and this is why we get together and do these types of lectures. CSF hosts 2 medical conferences a year. There have been books published from these meetings, and I believe Dr. Vorster has attended those in the past. We continue to set up chapters around the country, and this is to help spread awareness, educate, and raise funds through the events like the United Night Walks. We are thrilled. Last year we raised $175,000 through our United Night Walks. We had 62 walks on the map. This year again we have about 62 maps, and we're about halfway through them. And one of my jobs is to oversee all those walks. So we're in the middle of walk season and having a ball. If you would like to get involved, there's still time to do a solo walk where you just register yourself, ask family and friends to support you or join your team, and you just go walk in the neighborhood. And you could still earn the t-shirt and different things. I know, Laura, you were at a walk. You brought your gang out, and it was great to see you out there. CSF continues to host their signature events. Okay, oh, they want you to log in, huh? I can just close that there. We have the signature events like the Bobby Jones Classic Golf Tournament and other events in Staten Island, Chicago, DC, New York City, and the 7th annual Dinner Dance for a Cure is coming up right around the corner here. And it's Dr. Vorster is going to be our medical honoree this year. So again, we're thrilled to have him part of everything. It's a fantastic evening filled with great food, music, fun, friends, auctions, and hope. And I hope you can join us. One huge project I want to briefly mention is something called the Common Data Elements and the International Patient Registry Project that is ongoing. This has been a huge research project that's been being worked on for years. And basically what I want to say about it, the truth is, many physicians agree that the definition of Chiari must be re-examined. Is Chiari a certain level of tonsillar descent, 5 millimeters, 3 millimeters? Is it 0? Is it instead just a particular set of symptoms? None of the above. Where does that leave all the comorbid conditions like Syringomyelia, Ehlers-Danlos syndrome, and the many others? This lack of clarity is a big problem, and it makes it difficult to determine which patients need surgery and which patients do not, and how to help the patients. Recognizing this problem, CSF staff and members of the Scientific Education and Advisory Board have been meeting after hours for over 3 years now, and they have written with the NIH something called the Common Data Elements for Chiari Malformation. And what this will do is it's common data instruments and clinical research forms for Chiari, and these help standardize the measurements and instruments that researchers and clinicians will use in their research studies. The documents are now public on the NIH website. It was a huge labor of love. This was the first step in the long-term plan to help understand these disorders better. Next is the International Patient Registry that you will continue to see more information come out regarding this project, and hopefully you can get involved with it. While we are clearly very busy, we have 4 full-time employees, and we're constantly running with all we do. But we all have a passion to make a difference. Research and development are very expensive, and we are always looking to fund more chapter lectures like this one tonight. So to keep moving forward, we hope that you can get involved to help us raise awareness and to help us raise the desperately needed funds for research and education programs, and we'd love to see you get more involved. Thanks. So Dr. Charl Vorster is a board-certified neurological surgeon. He is a neurosurgeon at the Cleveland Clinic with his primary location at Fairview Hospital. We at CSF are so grateful for him and everything he's done for CSF. He's helped do a lot of lectures for us, and we're thrilled that he's involved with us. And most importantly, everything he's done for patients who face a constant battle with these disorders. We appreciate his interest in helping Chiari patients, and we are honored to have him with us here tonight. It is with great pleasure I introduce Dr. Charl Vorster.
Good evening, thank you. Thanks for coming out. Let's get right to it. We know that Chiari malformation has a lot of information, sometimes a lot of confusion, and generally often differing opinions from physicians and from patients. And I intend to give you some information, maybe help educate you. I don't profess to have all the answers or the right answer or the best answer. I'm just going to tell you how I approach it and try to remove some of the fear that we might have as patients or even as physicians about what the right way is to treat this and how to approach it. So let's start right at the beginning. And I'm going to go right back to the beginning because I find sometimes when we discuss things like Chiari, we tend to launch directly into which surgeries and which type of graft and what about Ehlers-Danlos syndrome, and it gets confusing very quickly. So how about we just go right back to the beginning. So let's look at a normal MRI for starters. I don't know if we have a pointer over here somewhere, but this is a midline sagittal view, which means the slice that goes through our noses from front to back. And these are the slices that are most often used to discuss and describe the findings of Chiari. This is a T1 weighted image, which means that the spinal fluid is black and the gray is tissue. And these images are used when we're looking at anatomical detail. So T1 weighted images are one of a whole host of different kinds of images that we get in MRI technology. But this is the one that we prefer for anatomical studies. Now, I don't know if you can see, oh, you can. So we identified the midline by looking at this big C-shaped structure here, which is called the corpus callosum, which connects the two hemispheres of the brain. We see the supratentorial compartment, meaning the brain. Then there's the structure over here called the tentorium, not clearly visible here, which separates the supratentorial from the infratentorial. And what we're focusing on is the infratentorial, or the area below the tentorium, which is all of this. The infratentorial space contains the brain stem over here and the hindbrain, or the cerebellum, over here. And the idea is to look at particularly the area around the foramen magnum, which really means the big hole at the bottom of the skull. And as many of you know, the central issue is whether these structures at the bottom of the cerebellum, called the tonsils, whether these structures are impeding the flow by descending into the spinal canal at the back here. Now I'm starting off with a normal scan because it's just good to look at this for a moment. And let's pay attention to the area around the base of the skull here. We'll see the bottom of the clivus, which is this triangular bone over here, which is in the back of the throat. And you can already see that it's sometimes quite difficult to identify the most lower aspect of it. So herein lies already the first possible variability in that different observers might measure from different points. And we look at an area from about there to where the occiput or the basi-occiput bone ends over here. Now behind the hindbrain there is an area here called the cisterna magna, or really a collection of fluid. And this collection of fluid is supposed to absorb some of the pulsatile flow that occurs in the brain when the heart beats. And when this area is occluded, it's felt that some of this pulsatile flow might cause some harm or some damage or some painful stimuli by causing pressure on those areas. Now I'm putting this up on purpose. This is one of my patients who went to college, worked for more than 2 decades at the City of Cleveland, and is basically asymptomatic and goes on with his life. And he walks into our clinic. And so I'm putting this up on purpose because when we start talking about 3 millimeters and 5 millimeters and these kinds of things, we have to ask ourselves, and I warned you that I was going to go back right to the beginning, we have to ask ourselves, why is it then that people that have these sorts of abnormalities that are grossly abnormal when you look at it are able to be pain-free and functional? When we move on a little bit, we look at this example of somebody who had an MRI. Just, by the way, all the scans I'm showing you are actual patients of mine within the last 2 years. Their names and their dates have been taken off, so nobody knows who they are except me. And I'm not going to give their identity away either. But this person, for example, had a scan, and this is an incidental finding. So they had a scan because they were in a car accident. People have scans because they have a variety of reasons. And the radiologist will report that there is tonsillar descent, tonsillar herniation, Chiari, tonsillar ectopia, different words are used. And I think we can recognize that in this case, this area has descended downwards, and that fluid space, the cisterna magna, has been obliterated. So this case is a typical example of an incidental finding. And now the question becomes, when does a disease become a disease, since this patient has no symptoms from this area? So that brings me to the part where my patients have told me they find it very helpful when I explain to them, because it takes some of the fear out of the condition. It helps them understand how I think about it. And so I'll share with you some of the information and the drawings that I typically make for them to explain what's going on. So the first thing we have to ask ourselves is, what is a disease? Well, a disease is typically some type of abnormality of structure, like a broken arm or a tumor or something like that. Or it's an abnormality of function. My heart's not beating right, or my blood sugar is too high, or something like that, which causes problems then for the patient. But even that definition is very simplistic. And if you go on the internet, you look at the World Health Organization or hundreds of other websites, and you try and look up what the definition of normal is or the definition of disease, it's not as simple as one thinks. So we have to ask ourselves, when do we really need to treat people? Or when does somebody really become sick to the point that they are supposed to be having surgery? So that immediately brings us to the next question, and that is, what is the natural history of a disease? So the first thing a doctor thinks about is, what is the natural history of a disease? So let's say we draw our first picture. Let's say over here, we feel 100% normal. And let's say time passes over here. So some diseases, I'm happily carrying on with my life and I start coughing. So I don't feel quite 100%. Do I have a disease quite yet? Do I have a cold? Do I have a lung tumor or something? Do I have tuberculosis? Who knows? So maybe I don't even go to the doctor. I get a little bit sicker. Maybe now I've got muscle ache. I take an Advil, I'm still not going to the doctor. Maybe I develop a fever. I'm getting sicker as time passes. And the doctor may or may not give me some type of antibiotic maybe. And then hopefully I'll go back and I'll be normal again. So this is the most simple example of a disease and why we have doctors and hospitals. Because we get sick and we get better again. Now some diseases like the one I just described has a nice linear type of, if we didn't treat the patient over here, maybe they would have gotten pneumonia, maybe they would have really bad pneumonia, and they could actually eventually die from that, as we know. So that's why we choose to intervene. And why did we wait until there? Why didn't we just treat it over here? Because we'd be treating too many people that just maybe coughed because they had a minor cold or something. So it's up to us to decide at which point we want to intervene, how far are we willing to let it go before we know we can go back. Now, unfortunately, not all diseases follows this simple type of linear progression. Some diseases, and Chiari might be one of them, the patient's progress might be something like this. So meaning, you get told one day you have tonsillar descent, like the incidental case, and you might have that for many years until one day you develop quite severe symptoms sometimes, maybe less severe. But as you can imagine, if we chose to do surgery on somebody over here, maybe it was unnecessary. So at what point should we intervene? Well, maybe we'll all say, well, intervene over here when they get sick and before they get really sick. Well, that would be great, but how do we know? Maybe the person just has a headache. So you can see, this is the first principle we have to think of when we think of Chiari and how to intervene. Let's go to a next principle, and this is my next picture. Remember, we're talking about individuals. We're not talking, this is a disease, but let's talk about the individual. We're all different, right? And Chiari is a supreme example of a disease that has an extreme individual variation. As you know, if you look up the symptoms for Chiari, you'll see long lists of symptoms, usually with occipital headache near the top, and then it goes down from there and ends up with all kinds of things. So if most of us look at these lists, we'll find 3 or 4 of these things that might be applicable to us, whether we have Chiari or not. So clearly we're all very different. Even when we get a cold, we're different. Some people get a fever, no muscle ache. Some people just cough, but they never have muscle ache, they never have a fever. So we know that this concept of individualization is very important. So let's go then with the second concept. The second concept is this individual variation. Now normally, let's say all of us go for a run right now. Some of us will get tired before others. So we know that, let's say, a normal person will have a reserve like this. Let's say this could be anything. We're good at measuring cardiac reserve or respiratory reserve. We can have somebody go on a treadmill and we can see if they feel sick or get chest pain or something. So we know they've exceeded their reserve. So most of us live inside here. I'm a little excited, maybe I'm sleeping and so forth. But I'm never exceeding my reserve at the top or the bottom, so I'm not really feeling sick. Now, it might be with Chiari that if somebody has a little bit of tonsillar descent, maybe their cisterna magna has been obliterated, but they don't quite have the 5 millimeters or something like that, let's say. But they have limited reserve. So if everybody then has a head injury, for example, the one that has the limited reserve will become sick. So we often see people that have some sort of tonsillar descent, some degree of that, but their symptoms were elicited after they had a head injury or if they reach a certain age, because tonsillar position also changes with age. So we know in young adulthood, even in normal people, the tonsils descend. In young adulthood, they're at their lowest position and then they go up again. So that might explain why a lot of Chiari 1 malformation patients present in early adulthood. The third thing we have to think of, besides individual variation and natural history, is what Kathy just brought up, related conditions and comorbid conditions. So even if all of us had exactly the same disease, we all have exactly the same pneumonia or the same broken arm or the same Chiari, there still remains a difference between us, because not all of us have the same comorbidities or related conditions. So what is a comorbidity really? Well, from a surgeon's perspective, it's something that would affect your treatment. So for example, if you have a bad heart and you've got several chronic diseases, my decision about whether I'm going to do surgery on you has to be different than whether I'm going to do surgery on somebody that has virtually no chronic diseases. So that's what a comorbidity is. It makes things more serious or more dangerous or more complicated. A related condition is probably something that's more actually involved in the actual pathophysiology of Chiari. For example, pseudotumor cerebri or spinal fluid leaks or congenital abnormalities or various things like that that could be problems on their own, or they could be related with Chiari and make things more complicated. So if you have a connective tissue disorder and you have tonsillar descent, you might need a different kind of surgery or treatment than somebody who has exactly the same tonsillar descent but no connective tissue disorder. So that's also something we have to remember. Then the fourth one is when we think of diseases, typically when somebody goes to medical school, you get taught the first thing is you get the history. You find out what the story is. That's what you're supposed to do first. And that's most important. And I'll tell you why that's important for our discussion. The next thing you're supposed to do is a physical exam. And then you're supposed to do tests. And the tests are supposed to confirm what you already know. It's not supposed to tell you something that you've never heard of. You're supposed to think, well, this patient seems like they've got pneumonia, so I'm going to do a chest x-ray and confirm my suspicion, and then I'm going to treat the patient. Now, unfortunately, what happens in Chiari, like in this case, the test now comes first. So now we're all focused on the imaging, but we haven't really listened to the patient. And even though we might have examined them, there's often not very much to find or something specific that you can look for. So you can look for some specific things, fasciculations on the tongue, nystagmus of the eyes, Baton scores for connective tissue weakness and so on. But it seems like the whole system has been turned backwards. And so we have to be very careful that we don't just treat people on this without looking at that. And even the patients themselves, not only the physicians, have to be careful that they don't feel they need treatment and that they maybe, in retrospect, you know, we're all human. If something happens to us, we always tend to think back, was there a cause? Was it because I bumped my head when I was a child? Was it because I was in a car accident? And we make links to things which might not be linked necessarily. So let's get to the next and last picture. After all of that, we have to ask ourselves, so all right, let's say we've got the diagnosis now. Whoops, this thing's a bit wonky, I'm sorry. Let's say we have the diagnosis. The question then becomes, what is the pathophysiology? So this word means, like, what is really making the person sick? What's going on? So if you have pneumonia, you've got bacteria in your lungs, and the body reacts to that by forming inflammation, and so then it plugs up the lungs, and then you can't breathe, and then you run into problems. So that's the pathophysiology of the disease. So you have to decide at what point you want to intervene. If you're early, you can kill the bacteria, but later on you might have to kill the bacteria and put the patient on a ventilator, depending on how far you are. So with these disorders, we have to know what the pathophysiology is. And I think all of us that are interested in it knows by now so this is the head, and we have the brain, the cerebrum, we have the hindbrain, the cerebellum, we've got the brainstem with the pons, and here is the foramen magnum. And normally the fluid has to flow through here, undisturbed, back and forth between our brain and our spinal cord. So when we put all of these things together, it seems like the main pathophysiological problem with Chiari is that this fluid is being disturbed. And that's why the treatment and the surgery focuses on this. And it's disturbed by these tonsils going down in there and eliminating the flow to some extent. Could happen in the front as well. So that is what we have to think of with the pathophysiology. So let's move along. So here's a typical case of a Chiari. We have the picture that we're all used to seeing on the right-hand side. We can see the bottom of the clivus and the bottom of the occiput, and we get the impression that there's a lot of crowding, as we say, at the foramen magnum. So we get the impression that fluid down here is not really flowing through to connect to the fluid in the head. And if we look closely, we can see a Syringomyelia down here, where there's fluid collection in the spinal cord because of this obstruction. Occasionally you can see coronal views like this, which means the view from the front. So this person is looking towards us in the audience, and we can see some tonsillar descent over here. So most people would probably agree that this is at least a Chiari malformation where somebody should at least consider treatment. Although even here, not everybody would agree, because this patient might have no symptoms despite these findings. And we might say, well, if somebody has no symptoms, why would we subject them to surgery? But we probably will keep monitoring a patient like this. In this case, you might look at this and say, well, it doesn't look quite as bad as this last case, but what's going on up here? So this patient has obstruction of the fluid at a higher level. The obstruction's occurring up here, and it's causing some pressure, pushing things down. So if we wanted to treat this patient, we probably shouldn't focus our attention on treating down here. We probably should focus our attention on treating up here. So this patient might need a shunt, or an endoscopic ventriculostomy, or some type of spinal fluid diversion procedure to get rid of whatever's obstructing up here. And then maybe this will never require treatment. What's happening over here? Well, to the untrained eye, it might not be that obvious, but we can see how flat the skull is at the bottom. We can see how steep the tentorial angle is. So this would generally be put in a complicated group of patients that have cranial cerebral disproportion, which means the brain just doesn't fit comfortably within the bony confines in the skull. And this case might be something close to platabasia, and there are many measurements and things that people come up with to try and define things like basilar invagination or platabasia, which are complicated conditions that are even difficult to quantify exactly. But that's what this is. Another one might be this. We'll look at this and we'll say, well, that looks pretty normal. Here's the corpus callosum, the brainstem, the hindbrain. We can see there's a little bit of descent here below our McRae line, which is the line from there to there. A few millimeters of descent. If we're not careful and this patient has a lot of symptoms, for example, this patient might end up with a Chiari decompression surgery, unless we really go into, remember, the history first. So when we start asking, talking, finding out what's going on, it prompts us to look around a little bit. And this patient has a spinal fluid cyst in the lower end of her spinal sac. And she's been having spinal fluid leaks down there. And so basically the tonsils are being pulled down. So if we did a decompression surgery on this patient in the back of the head, their symptoms might become worse instead of better. So we have to be on the lookout for these things. How about this one? Well, now we're seeing a more severe tonsillar herniation, for example, over here. We can see a lot of crowding in the area. But there are two other things we should notice. We're noticing several disc bulges here in the cervical spine, and we wonder if those might contribute. People that have narrowing in their cervical canal might have many of the symptoms that people with Chiari have, things like imbalance, incoordination, numbness, tingling. So we have to make sure this patient doesn't have what's called cervical myelopathy, which means narrowing in the neck. They might have two problems. Then we have to decide which one is the easiest to treat, which one might have the biggest impact if we treat it. So this is a complicated case. We'll also say, well, besides the tonsillar descent over here, we're also seeing this. We're seeing a very sharp angle here. This is called a retroflexed odontoid. So there's a combination of abnormalities at the skull base there. And if we did a decompression from the back, like we normally do Chiari surgeries, we might still be stuck with significant mass effect over here in the back of the patient's throat. Well, then the question becomes, well, can you operate in the back of the throat? Yes, the answer is yes, we can. We can operate through the mouth or through the nose with cameras. But these are surgeries that are much more invasive. And if we do that, and if we remove some of these structures over here, the patient then also needs a fusion in the back. Now, what happens if you fuse somebody's skull to their cervical spine? Well, they lose more than half of the motion in their neck because you can't say yes and you can't say no. Kind of a difficult problem to have. You can move a little bit, but you lose a lot of function. So do you really want to subject this patient to 2 surgeries, one from the front, one from the back, with 2 sets of complications and the loss of motion in the long run? As you can see, for that we might need a higher threshold to convince ourselves that the procedures and the complications that we're exposing the patient to is worth the benefit that we're going to be having. And this is what we discuss when we surgeons sit and we try and think of, we discuss things like, well, isn't it possible to position this patient in a good position and only operate from the back and only fuse them from the back and reduce some of the motion? That's one of the trends that we're looking at, which seems to be at least somewhat successful, so you don't have to do the surgery from the front. But just to give you a flavor of the things that we're thinking about. And then maybe even this one. I don't know if spontaneous resolution is really the right word. I don't think things ever really completely resolve on their own, unfortunately. But sometimes the symptoms get better, and sometimes these things have a way of looking better on MRI sometimes. So you can see over here on the left-hand side, the patient has some degree of tonsillar descent once again, a large Syringomyelia in this area, no sign of bulging discs or trauma that may have caused this. So we have reason to believe the Syringomyelia is caused by obstruction at the base of the skull. But these 2 scans are 4 years apart because this person is a very active sportsman and he decided, I don't want surgery. And he started developing symptoms. When he came back, we did a new scan. We were probably expecting all this to look worse, and now it looks like this. And now we're thinking, well, what to do about all this now? So these are the things that are not clear-cut, and that's why patients are sometimes confused by what they read on the internet or what different doctors say, because as you can see, these things are not easily entered into an algorithmic way of thinking. If we put this into IBM Watson, who knows what will come out the other side. How about this one? We're now moving to the treatment, so we've decided now to treat somebody. So here's a patient on the left, a lot of symptoms, significant Chiari, the wedge shape, slight bulging of the brainstem here, which means there's some impaction over here, maybe some early signs of Syringomyelia. So we decide we want to go ahead with surgery. And we end up with this. So what is this? This is a fluid leak. This is a Pseudomeningocele, it's called. So although the flow looks a bit better at the base of the skull and the decompression has been done, this patient feels miserable because they've developed a Pseudomeningocele. And so we have to go in and drain that sometimes. Not always. This patient had to have a drainage surgery. And we'll get into more detail about this in a minute. How about this one? Once again, our eyes immediately, because we're at a Chiari lecture, we're looking down here. We're seeing absence of the cisterna magna. We're seeing not much of a Chiari descent or a tonsillar descent. But we see in the pineal region a fairly large cyst, which could escape our attention if we're not careful. There it is in a different view. So this is causing some degree of obstruction here of the aqueduct. So once again, this patient might not need any surgery down here, but maybe rather some type of CSF diversion procedure. Once again, this might be an ideal case for endoscopic third ventriculostomy. And if we really go to the edge of unusual, what about this patient? So what are we even looking at over here? Well, we're seeing all kinds of scarring and things down here and in other parts of the brain. When we look at a cross-section over here, we can see the brainstem there, and we can see some portions of the cerebellum herniating into the foramen magnum. So this patient has neurofibromatosis, which is a congenital condition with tumors, scarring, and other things. So this is an example of subarachnoid scarring. So this patient has developed now, because of the scarring, the spinal fluid isn't circulating normally around their brain. So they really have subarachnoid scarring. So once again, if we start doing surgeries down here, we might have no impact on this. And then finally, just for interest, this is just a very unusual case that I saw recently that has this condition with enlarged CSF spaces. And once again, errors can occur. Somebody will look at this and say, well, maybe this is a syringomyelia or a syrinx that occurs in the lower brainstem. And they'll say, well, this looks pretty tight down here. And so there might be some people that don't see this. But if you look, I don't have all the cuts here, but there's also large spinal fluid spaces up here. And so this condition is an unusual condition we sometimes see in people that have nothing wrong with them. And it's called the Virchow-Robin spaces. Virchow and Robin are names of people that describe the spinal fluid spaces that are in between the folds of the brain, and in some people they're just enlarged. But it's not a disease that causes any problem for you. So we have to be careful to treat this patient surgically. How about this? You see this goes on and on, doesn't it? Now if we look at this brain scan, we see over here from the side, here's the eye and the face. You can see how the brain has been depressed by some fluid collection above the brain. So that's called a hygroma. So now the question is, well, so what? Well, it's causing pressure on the brain over there. It's also causing some degree of impaction at the bottom here. So what to do? Well, back to the history again. Well, doctor, I had sinus surgery a year ago. And I think things are coming out my nose, but they say I've got chronic sinusitis. I haven't stopped smoking. So the doctors have been giving me antibiotics. Well, are you leaking spinal fluid? Well, I'm not sure. I feel things in the back of my throat sometimes. Anyway, to make a long story short, this patient has a spinal fluid leak from her sinus surgery. So here the treatment has nothing to do with Chiari, but has to do with sealing the area where the leak occurred up in the nose where she had her sinus surgery. How about this? I just saw this man today in his follow-up. He's an avid gardener, works hard, likes being outdoors, and started getting severe headaches, started acting unusually. And that hygroma I showed you before, that's him. And so we wondered what was going on with him. We did this kind of MRI, which is called a heavy T2 weighted MRI, where the machine is able to separate out spinal fluid from the rest of the tissues. And as we see the spinal sac coming down here, we see normal looking nerve roots exiting, but over here we see all these cysts. Once again, back to the history. Yes, doctor, some years ago we were in a rollover, we were hanging upside down in the seat belts. And since then I like gardening all the time. I do everything, cut the trees, dig the trenches. He's retired now. And so basically he has a spinal fluid leak. These are even harder to prove or to identify. So it takes a little bit of thinking and a little bit of digging to identify this. And so thankfully we didn't operate on him. And when I saw him in his follow-up today, his hygromas have nearly gone away. So these leaks sometimes seal on their own. So the safest and cheapest treatment to get better on your own. Now we get to this one. And this is probably the most important one that shouldn't be missed, because I think this is the most complicated interaction with Chiari, is this condition. So what we're seeing here is very small ventricles. We're seeing small sulci, the brain looks tight. We're seeing this large fluid collection called the empty cella syndrome. So this patient probably has pseudotumor cerebri or benign intracranial hypertension. Nowadays it's called IIH because people didn't like the pseudotumor part, because nobody likes the word tumor in their diagnosis. Pseudo sounds like you don't really have something. And then it was called benign intracranial hypertension, and people said, well, it's not really benign, you can go blind from this, so let's change the name to idiopathic. Idiopathic, I like the word because I think the word idiot is in there somewhere, which usually means that we haven't figured out what the real cause is. And there are two schools of thought. There's the vascular school, which is this school, which says this odd-looking picture is an MR venogram of the brain. You'll have to believe me about that. And this is the midline. This is where a baby's soft spot is up there, to give you some idea. And you sometimes see this in a person who has a bald head or a shaved head. You see the two lines on the back of the head. These are the two big veins that split out and go down behind the ears. So this is called the sagittal sinus and the transverse sinus. And you can see this patient's transverse sinus on the one side is not flowing as well as on the other side. So there's a school of thought that says people have obstruction of some of these veins in their head. And if you put a stent in there, the blood can get out of their head better, and so their brains will stop swelling up. So you can see how far removed we are now already from Chiari, but the scan looks like a Chiari. So now we're ending up with stents, and it works quite well. This, unfortunately, is the minority of cases. The picture on the left shows the retina, the nerves in the back of our eyeball, and this over here is called the papillar area, and this is called papal edema. So instead of a flat kind of a surface with a dent in it, this is supposed to look more like a volcano if you use a bit of imagination. So yeah, you can kind of see the rim of the volcano. This is hard to see in the office. We can see it. I sometimes turn the lights off to see if I can see it. If you go to a neuro-ophthalmologist, they can see this with their special machines. But these are the kind of tests that are needed then to make sure somebody doesn't have IIH. So now we get to the last few slides of our lecture. On occasion, because the Cleveland Clinic is obviously a referral center for many patients from all over, and we keep track of this, and at the moment we're at about 32 states that we've seen for Chiari patients, and 2 from other countries, so that's our numbers. We see this not infrequently. So this patient has had a surgery, but you could see the bone that maybe was down here somewhere has been removed all the way to the bottom of the tentorium. So there are surgeons that believe you should do a very generous decompression in the back of the head, and since we're surgeons, we like to do things properly. So sometimes you can even do it too properly. So some doctors believe that you can't ever make it too big. I'm sort of in the opposite school. So we take great care in measuring exactly how large we're making the enlargement. And we try to do it on the smaller side rather than on the very large side. Because if you're on the very large side, you might develop all kinds of symptoms because your brain might sag down a bit. And then doctors really roll their eyes when you get to their office because it's hard to pinpoint where your symptoms are coming from. So we've done a few selected cases where we reconstruct this by putting a plate on here to give some support to the brain. But it's very difficult for me to predict what the benefit will be for this patient. So we discuss with them what we think the problem is, and that the outcome is very difficult to predict. But of the ones we've done, most of them feel better, they tell me, except one that's kind of the same. So this is the kind of surgery that you don't want. So it's better not to have the over-decompression initially. So I thought I'd just show you, and you can see over here, to make things worse, the decompression is mostly, here's the foramen magnum, but the decompression is sort of big up here instead of maybe a little bigger on the side and not as high. So some surgeons do kind of a heart shape instead of a wide shape because it's technically a little bit more demanding and a little bit more work to get into the side here, maybe a little bit more dangerous. See the big blood vessel here. So, but it's easy to just keep going up, so one has to resist the temptation to over-decompress a patient. And this is the goal. Of course, you'll only see my best pictures, but this is one that I feel proud of. And of course, I've never had a failure. Now, we all have failures, and but this is a very good case. And by good case, I mean the tonsils that have descended down here are back up there, and we'll discuss that in a minute. And the Syringomyelia is gone, and the patient is happy. And obviously, it's not the end of the story. We'll have to see what happens in 5 years or in 10 years. So let's just talk about surgery for a moment. And it's difficult to show you slides of that. So I'll go back to my diagram and we'll finish off with this. Because this is something that also creates a lot of uncertainty and confusion and anxiety with patients. So the surgery really consists of, number one, you do the posterior, oh, this is too small. Let's just say you do the bone in the back of the skull. I think pretty much everybody that does Chiari surgery does that. As we go down the list, things become more dangerous and more controversial. So I think everybody does bone on the back of the skull. Then the second thing is, what about C1, my first vertebra? So C1 is not really controversial, but it's not always necessary. It doesn't really add much risk to the surgery. And I would say probably the majority of Chiari procedures include C1. Laminectomy, meaning you remove the back arch of C1. Then we get to the one that everybody loves, which is the dura. The duroplasty. This part of the procedure has received a lot of attention because of many reasons. The first thing is the moment you open the dura, you're opening to the chance of a whole bunch of complications, most commonly a leak. And so the results of leaks, when we look in journals and so on, it's always, I think 0 is not realistic, but it goes up to about 20% at worst. So this is a scary number. Who wants to have a 20% chance? I don't think those numbers are correct. I think at centers that actually look at their outcomes like we do, our results are probably, I would say it's maybe about 4% or something like that on average. Not my own results only, also my predecessor, Dr. Luciano. So if we look back at the pseudomeningocele and reoperations because of leaks, it's maybe in the 4% number. And when I go to meetings and listen to people that I respect, that's sort of the number that comes up a lot. So I think that's maybe a realistic number. The second problem with the dura, opening the dura, is that obviously now you're inside the brain. Before this, you were outside the brain. So then we worry about what can go wrong inside. If there's some bleeding on the inside, you can get arachnoiditis, scarring. So that's the second complication that could occur. The third is, you might worry that people have allergies or something. I think the whole allergy thing might be a little bit overemphasized, I imagine. I don't think it's really such a big thing, but there are certain cases. So I think that's a small consideration, an allergy to the type of patch you're using. So that's the duroplasty. So there were several studies, including at the Cleveland Clinic, where we tried to say, well, let's choose people who need this. Let's not just do everything. Let's choose ones that need the dura opening by doing an ultrasound. So when we turn the patient over, let's do an ultrasound and see if it seems like they need a duroplasty or not. Those studies have not really been that promising because doctors have noticed that if you even just turn the patient over without doing anything, the flow improves. So there have been recently studies where people have done very complicated things to do, scan people when they were asleep, turn them over to do the surgery, scan them again with the intraoperative MRI, and then they noticed, oh my goodness, it already looks much better just flipping them over. Well, now, of course, we flex the patient's neck when we do the surgery, so maybe just the position flexor opens up the space a bit. So that makes it very difficult to study, really, to try to come up with a reason why you should or shouldn't do a duroplasty. Maybe the only reasons you don't have to do a duroplasty is if you, I think in small children, of which I'm not an expert, they often decide not to do this because some growth and there's a dynamic system while you're still growing. Or if patients have some particular fear about it, the doctor might say, well, all right, we won't open your dura. Don't know if that's such a good reason to do it from the doctor's side. But anyway, the fourth one is to do some dissection on the inside. Let's just call it arachnoid dissection. These are little scars and membranes and all these kinds of things. You might remember the case I showed you with the leak. That lady, you might say, well, why did he open the dura? Because I opened her dura. Well, thank goodness I did, because on the inside there was a membrane covering the bottom of her fourth ventricle. So had I not done it, she might have not had a leak. Well, she definitely wouldn't have had a leak, but she wouldn't have been better either. So then what? So arachnoid dissection is something that's done under the microscope. And then finally, probably the most controversial of all is the tonsil cauterization. And that's what this patient had. So, I mean, these tonsils didn't go up there by themselves. I cauterized it. So then immediately the question becomes, wow, that sounds dangerous, doctor. Are you really going to cauterize part of my brain? Well, that's one of the humbling and dangerous things in brain surgery that we always have to consider, is what can we do and what can't we do. And we have to understand that in the brain, not everything is important, but everything is not equally important. So in some parts, we can, you might say, we have more freedom to be able to do these things, where in other parts you can't do it. So there's some parts of the brain where you don't even want to touch it, and there's other parts where you can actually even remove large parts, including in the cerebellum. And the way we know this is because some people have a stroke of their hindbrain. So they clot off an artery and they stroke their hindbrain, and it swells up, and they're going to die if we don't do something about it. So we get called in emergently, and we remove large parts of the cerebellum, sometimes half the cerebellum we remove to save the patient's life. And these patients are remarkably normal. And that always struck me, how is that even possible, that you can remove anything out of somebody's brain and they can still be normal? Well, part of it is plasticity, so you can grow new connections again, but I don't think that's what's going on there. I think sometimes you can disrupt the network up to a point and then it collapses. And I don't know if it's really a good analogy, but I sometimes tell people, if we block off 77 in Cleveland, there's going to be a traffic jam. If we block off 306 or Lorraine Road or something, there might be a fairly serious traffic jam, but not so bad. If we block off the road we live in, maybe there'll be no traffic jam. So the question is, how far can you go? And this is where it comes, where we have to make the judgment. And it turns out that the tonsillar area is something that we can coagulate, but we have to keep several things in mind when we're doing this. The first is to be careful not to overdo it, and that's not something that's easily definable. The second thing is not to harm some of the large vessels in the area, most importantly pica, which is the artery that goes to the bottom of the hindbrain and the brainstem. So if one takes these things into consideration, you can do it and achieve a wonderful result. But there's no simple way of saying always the same thing or not. It would be like saying a quarterback's only allowed to throw the ball 10 yards, never 20. Now we all know that the further he throws it, maybe it's not even true. But we would think that the further you throw the ball, the more there's a chance of something going wrong. Which, as I said, I'm not sure if that's necessarily true, but let's just make it true for now. So we know that the more we do, the more harm can be done. So when I talk to patients, I say to them, well, if you're going to ask me about that, I do everything. I do everything that's needed, I think. And I felt emboldened recently when I went to one of our gatherings of neurosurgeons, and it seemed like most people that I respect are doing the same at the big centers. So if there's an opportunity for us to not do something, sometimes I've left parts of C1 in, or sometimes, we don't do much dissection. Sometimes I don't even cauterize the tonsils. But these are one of the things where you have to say, well, let's see when we get there. And that's unfortunately, it depends on the surgeon's style. I know that's not the modern way of thinking. Everybody wants to have an algorithm and a specific, and we don't have complete freedom to just do what we want to. But there is an aspect where we can't tell the quarterback, never throw the ball on the third down, or always run the ball on the first down. I mean, you could probably statistically come up with that it's probably better to do this or that or something. But we're talking about people's brains and not about football or other things. And so I think I have comfort in what I'm doing, and I can honestly say I haven't had serious neurological complications where I wish I didn't do something. When I do these surgeries, I'm mostly concerned that the patient might not have all the benefit that they were hoping for, because we can't clearly say that all your symptoms will be going away and you'll be completely normal. So that's one thing I think about, and I hope that if we screen people properly, they will have a good outcome. The other thing I worry about, just a little bit, not much, is to make sure that the patch is very watertight, because we do that anyway. I don't worry about it. And we ask patients to cooperate and not to overdo things in the first few weeks after surgery. But sometimes if they're very nauseous, the one that I had, the leak, she's the only one I've had now in 2 years since I've been doing this after Dr. Luciano left. She was nauseous for about 3 days and hurling and just feeling uncomfortable. So I'm sure that probably played a role in the leak that she developed. But anyway, it could be fixed, and it's not a problem, and she's doing well. So with that, oh, this silly thing has popped up. I think we've reached the, I don't know what happened now.
You hit play again, it should come back up as soon as you hit the first slide.
You mean like this?
The last slide or whatever.
You mean like this? Oh gosh, we don't want to see all that again. Just wanted to show you one last slide, which is interesting, to emphasize my point about doing all of these things most of the time. So this thing goes from the left to the right. And there's several years here. The person on the left, it's the same person. So the picture on the left, I don't know how well it projects, but there's a significant tonsillar descent with a large Syringomyelia next to it. This patient had a surgery over here, but the dura was opened, but the dura wasn't expanded because we got the old operative notes. So I think the surgeon incised the dura but didn't add a patch to enlarge the whole area. And so there was some degree of benefit, but the patient became symptomatic again and the syrinx got large again. And so we eventually decided to go back in and do a revision and open the dura and do the dissection on the inside. And you can see some of these tissues are scarred, and it's dangerous to go and work in here too much. But just the fact that we opened up and put the duroplasty and I opened up the fourth ventricular outflow, the Syringomyelia has already gotten smaller. But you see at this point, we're playing catch up a little bit. And so that's why, as a surgeon, for me, I think your first go is your best chance of doing it properly. And that's why I encourage all of you, not necessarily to come to me, but to make sure that you get a few opinions and educate yourself as well as you can, and write down your questions and think about it. Don't make yourself sick over it, because you're not supposed to be a neurosurgeon, but make sure you ask about the things that bother you. And we'll end there. And I put this picture up there because thank goodness this guy doesn't need a Chiari surgery. I don't know. So if you have any questions, go ahead.
I have some.
Sure.
I had the decompression done in 2010.
Okay.
And about 6 months ago, I started with the same symptoms, the headache here. Mostly if I'm laying down, it gets really bad. It wakes me up at night and I'm awake.
Yes.
But I got a lot of numbness and weakness in my arm.
Yes.
And how much of a chance of coming back is it from my Chiari?
It's a good question, because as I said a few times, because we're individuals, it's hard to take everybody as a group and say it only occurs, this percentage of time or that, because we don't know. Well, I don't know what kind of surgery you had exactly, or what the symptoms were before, or what the individual.
Kind of the same. And I don't have the weakness in my legs or the numbness in my legs
Okay.
or my hands. I just have a weakness in my arm that I didn't have before, like a pain and a weakness in there. The headache is the same. The ringing in the ears or back, it's the same. But I don't have all of the symptoms that I had before.
Well, you could have developed scarring or obstruction of your spinal fluid flow again. It's possible.
I know if I move my head just right, I'll get like real sharp pains in the back. And where she did the decompression is sunk in more than it used to be.
Well, I was just going to say, I see many patients like yourself. And then what we typically do is we repeat the imaging, obviously, and we look around to see if we see something obvious that we think can be fixed surgically. But we have a much higher threshold for going in the second time or the third. I've had people that have had 4 Chiari surgeries. I didn't know you could do it 4 times, but I've seen patients like that.
I thought once they did it once it was fixed, but I guess not.
Yes, well, it's a dynamic. In biology, you know, everything is dynamic. If you trim your trees, you know it's fixed, but it's not fixed forever. It's not quite that bad, but it's not like every season, like every year. But there are other things that can cause many of the same symptoms. What we see a lot is that, exactly as you mentioned, the incision and the way that the muscles have atrophied and so on often cause problems for people. With many, it won't cause weakness in your arm, but it could cause headaches and spasms and so forth. So we often advise people to do neck exercises because some might also have some degree of instability, perhaps, it's possible. Some people might have had, during their index case, their original case, may have had a bit of bleeding inside of the dural sac. So that causes scarring that maybe takes some years to start, sort of like a cobweb, to originally start affecting the spinal fluid flow. That's another possibility. It could have been, of course, be something completely different, even though it feels the same. You might have, if you're getting a little older or you've had some wear and tear on your neck, you might have bone spurs or disc herniations. So the same goes for recurrent symptoms as for the first time. You have to make sure that we don't go down one of the wrong paths of all of these things that I described tonight.
Yeah, I don't know if she opened up the door when she did it or not. That's something that I didn't know anything about until she was asking me.
Well, most recently people have tried to say, well, isn't the central question, if we don't open the dura, then we skip the leaks. And I said, well, some people think it's 20, I think it's 4, so let's say the answer is 10 or 12 or something. Well, let's make it 10% of people might leak if we took everybody in the country. So we'd like to avoid this 10%. So that's a good reason to maybe not open the dura. Then immediately the question arises, well, if we don't open the dura, how many people would we be missing that has some type of intradural problem that we didn't see? And people have actually studied that, and the numbers there are about 12 to 16% or something. So as you can see, it's sort of, it's close. It's not overwhelmingly to the one side or the other side. So as a surgeon, knowing that if you go back, things are always harder and more dangerous and so forth, to me it makes most sense to try and fix the problem completely while you have the opportunity. Now, I might not always get it right, but that's my kind of inclination or my approach to the problem. And so I still believe in that, and I hope that if surgeons do that and they do it safely and properly, not just open the dura and close it again, but actually go in there and do it properly, cut the arachnoid band, see the floor of the fourth ventricle, really put in the extra little bit of time and attention, use the microscope to do it. I have to believe that these kinds of things will be less, and that the fluid leaks can be kept to a minimum by, you know, second guessing yourself, changing your technique if you see that things aren't working, or using different grafts or better sutures or better post-op care or whatever, because the leaks, theoretically, we should be able to get very close to 0. It will never be 0, but close to that if we can. So to me, that mitigates for, let's open the dura on everybody and do it properly, unless you really have a very small Chiari or some particular base of skull abnormality where you can maybe just do the bone.
Mine was a 9. Have you ever had, in your doing the surgery, somebody's skull being very, very thick?
Yes, we see both variations of this. So we know that there's a congenital, obviously, component to this. Not everybody, but probably the majority. And so we've seen very thin skulls, very thick skulls, different types of shapes to the skull. it's never exactly the same. Some people even have little defects at the bottom of their foramen magnum. Some people have partially fused C1s, or sometimes a gap on C1, like a cleft palate, where C1 looks like this. It never closed. So we see a lot of variation in that area.
Because that's what mine was. She said it was very, very thick. It took her a lot longer. I was in for 3 more hours in my surgery than what she had planned on.
Oh, I see.
Being in there.
It sounds like your surgery was difficult for us. I don't think speed really means anything about people being good or bad or something. But our average surgeries are the fastest it ever goes for us, and we always do all of that, is about 1.5 hours, and the longest maybe 3 hours.
Yeah, I was in there for
And the average surgery is about 2 hours or maybe 2.5. So yesterday I did one and it took 2 hours and 5 minutes, and I'm not rushing and I'm doing all these things and I'm in no rush. There's nothing to prove. But I think that's sort of the time it usually should take. I hesitate to make conclusions from how long a doctor took to do whatever, because if you encounter a bleeder or something, you don't want the doctor to rush and watch the clock. But it sounds a little bit long, I'm not sure. Maybe a bone really was thick, or there were some technical challenges, which might then also explain why you're having a recurrence. I'm not sure.
Are you taking new patients?
You should be careful, and you should see many doctors, and humans are very perceptive. You should look at your doctor and look them in the eye and listen to them, and you should make sure that you understand what they're talking about and what they want to do to you, and then trust your own perception, because if things go well, everybody's happy. But if you have a problem, you should feel that whoever is dealing with you, that you feel like you understand what they're doing and what they're thinking and so on. I hear a lot of stories where people say the doctor walked in and said I need the surgery and walked out. Not that I'm that wonderful, but I think with this particular condition, a lot of information has to be exchanged. And I never operate on people without meeting their family and their cousin who's a physiotherapist in California, wherever they are, on the phones, whatever, because I know that if everybody's on the team, it usually helps us to get better, because humans, we hunt in packs. And so if your family and everybody's on board with you, when things don't go so well, they support you and so on, versus, on the other hand, if things don't go well, and your sister in California says, well, I told you should have come to our doctor, or you shouldn't have gone to that one, or you shouldn't have had your door open. And when that happens, people become unhappy. So I think from a patient side, you have a lot of the power too. Don't feel helpless. You're allowed to go to different doctors. I don't say don't go to 10 doctors. I mean, I've seen people that have gone to 10 doctors and they just, I don't know what they're hoping for.
Yeah, I haven't been back to her since I went back for my initial checkup afterwards, because she had to do 2 x-rays because she told me that it wasn't me. And I said I was the only one in there besides somebody had x-ray on a foot, and the neck is not a foot. So I had to go back in, and then I went back into her room, and she's looking at it, and she says, that can't be you because I took that bone out. And I said, well, did you take it out or did you not take it out? And she shoved it in the envelope, and she said, you're fine, you don't need to come back. And that was, I haven't had any trouble until 6 months ago, and it was in 2010 that she did it. But
well, I'm always sorry to hear, if you're a doctor, if I go to a lecture or to a barbecue for that matter, you're always a doctor, so people tell you stories, and many stories are bad stories. And it usually boils down to me that it seems like the doctor and the patient were sort of on different pages, or they just weren't communicating with each other. It's usually something like that, so I think communication is a bit of a two-way street, although it's, you're obviously in a weaker position if you're the patient than the surgeon. But you should stick to your guns and, have your questions answered. And if we're busy and we're too fast or whatever, we'll make another appointment, I'm on the blunt end of the knife.
yeah.
So you should make sure that you have the information you need. And we're all different, if you're a particularly anxious type, I don't even like a flu shot, then make very sure before you have something done.
Yeah, she seemed very good when I went to her first.
Yes.
She explained everything, the consequences, what could happen and what could happen if I didn't have it.
So my recommendation for you would be to follow up with your same doctor, because that person knows what they did and so on. Don't allow yourself to become doubtful unless there's really a big problem. But generally, if you follow, that's why it's so important to choose your surgeon properly in the beginning. Somebody that not the best one or the nicest one or the biggest hospital, but the one that you feel you're relating to, because when these things happen, it's easier for you then to walk a path with them and find out what's going on, or to believe them if they say, well, there's nothing more to do, or, you know, because I've seen a lot of patients, and you only have to log onto the internet to see it, where there's a large group of people that say, well, I wish I never had the surgery if I know what I knew now. There's another group of patients that say, well, nobody believes me, I want the surgery, but they don't want to operate on me. And when you look at all this, it seems kind of upsetting, I would imagine. So I think for each individual, one should make sure that you understand what this particular doctor that you're talking to is saying to you and what it means. And you know, you just sometimes click with people or you don't. Sometimes somebody comes as a very well advertised surgeon or politician or whatever, but you just don't click with that person. So that means if things are going to go wrong with you, it's going to be hard for you to communicate to that patient. So that's something that one should do in the beginning.